Hello everyone, this is Dr. Madhusudan Rao on the program I teach medical students. The topic of today's lesson is pleural effusion. We try to understand this particular disorder with regard to its definition and normal physiology of the pleural fluid that is produced in health and the various etiological aspects of the pleural effusion, its clinical presentation and management. Well, what is pleural effusion? Pleural effusion is the excessive pathological accumulation of the fluid in the pleural cavity. That is the space between the parietal and the visceral layers of pleura. In healthy persons, normally there is an amount of 10 to 30 ml of fluid in the pleural space. It helps smooth movement of the lungs during respiration as it acts as a lubricant. Well, the formation of pleural fluid is the function of the parietal flora. Parietal flora is perfused by the capillaries from the systemic circulation. And pleural fluid is formed across the pressure gradient between the capillaries and the interstitial space. And the amount of fluid that is formed is actively absorbed into the lymphatics, okay, and cleared. The amount of produced almost same as the rate of absorption. And pleural fluid gets accumulated with the rate of absorption is less than the rate of production. Well, there are so many disorders that can result in the excessive accumulation of the fluid in the pleural space. That could be the diseases of the pleura itself or the disorders affecting the various systems. According to the Light's classification, the pleural effusion has been divided into transitive pleural effusion and the exudative pleural effusion. The difference is classified by the Light's classification, and he has put forward 3 criteria to know the exudative pleural effusion and to differentiate between the exudative and the transitive pleural effusions. Well, before we go into the details of the clinical presentation and the management, let us see the various slides. Pleural effusion, as I told you, is the abnormal accumulation of fluid in the pleural cavity. That is the space between the visceral and the parietal layers of fluid, pleura. It is the parietal layer of the pleura which is perfused by the capillaries from the systemic circulation. And this is the layer, that is the parietal layer, takes active part in the formation and absorption of the pleural fluid in health. And visceral layer of the pleura does not take any active part in the dynamics of pleural fluid. Well, it is formed across the hydrostatic pressure. There is the pressure gradient between the capillaries and the interstitial space, and the fluid is formed across the pressure gradient. Normal fluid in the pleural space is of low protein content. Its protein content is around 1.3 grams per cent. It is a transited that is formed normally. Well, there are so many disorders that result in the pleural effusion. The diseases could be related to the heart, as congestive heart failure, as kidney, that is nephrotic syndrome, could be disorder of the liver, resulting in the cirrhosis of the liver, or nutritional in terms of hypoalbuminemia. And there could be other disorders related to the infection and inflammations that also results in the excessive formation of pleural fluid. So based on the protein content, Light has classified the pleural effusion, as I told you, into transitive and the exudative pleural effusions. Well, pleural effusion, remember, is the most common cause of morbidity and mortality related to the pulmonary disorders. Well, coming to the etiology. As I told you, Light has classified the pleural effusion into exudative and transitive pleural effusions. Exudative pleural effusion has to meet one of these following criteria, which are laid down by Lights. They are pleural fluid protein under the serum protein ratios. If it is more than 0.5, well, in the pleural fluid lactate dehydrogenase, its ratio of the serum LDH is more than 0.6. If pleural fluid LDH level is more than 2/3 of the upper limit of the serum LDH levels, if any one of these criteria is met with, that particular condition is defined as the exudative pleural effusion. Well, these criteria are useful when you are going about the diagnostic evaluation of the pleural fluid in the patients with pleural effusion. Coming to the transitive pleural effusion. Transitive pleural effusion is due to the excessive fluid formed across the pressure gradient. When there is elevated hydrostatic pressure in the capillaries that are perfusing the parietal flora, there is a movement of the excessive water with low protein content into the pleural space. That results in the transitive pleural effusion. The conditions that are responsible for transitive pleural effusion are congestive heart failure, nephrotic syndrome, cirrhosis of the liver, and hypoalbuminemias. In these conditions, there is elevated hydrostatic pressure with low oncotic pressure in the capillaries. That results in the movement of the low protein, high water content fluid into the interstitium, resulting in the transitive pleural effusion. Coming to the extrudative pleural effusion, it is due to the presence of protein-rich fluid in the pleural space. This occurs when there is injury to the vascular membrane secondary to the inflammation, and there is increased permeability of the vascular membrane to the protein-rich fluid. Okay, this results in the movement of the protein-rich fluid into the interstitium, which increases the interstitial oncotic pressure, thereby pulling more amount of water into the interstitium. That results in the exudative type of pleural effusion. You know, the conditions that cause the exudative pleural effusion that include infections, that is pleuritis, as pneumonia, tuberculosis, systemic inflammatory conditions like lupus, rheumatoid arthritis, malignancies, trauma resulting in the hemothorax, and lymphatic obstruction and asbestosis. There are a few uncommon conditions like pulmonary embolism, post-radiation injury. These things are going to cause disturb the integrity of the vascular membrane, thereby resulting in the protein leak into the interstitium, thereby facilitating the movement of the water across oncotic pressure. That results in the protein-rich exudative pleural effusion. Well, pathophysiology, we are already talked about it. It is basically the movement of the water-rich fluid into the pleural space across the pressure gradient. Okay, that occurs in the conditions which I mentioned earlier, like congestive heart failure, nephrotic syndrome, cirrhosis of the liver, hypoalbuminemia, etc. They result in the transitive type of pleural effusion. Those conditions which causes the inflammation secondary to infection results in the protein leak into the interstitium, which results in the exudative type of pleural effusions. This is basically the disturbance in the balance of the fluid dynamics that results in the pleural effusion. Either it is transudative or the exudative. It is our responsibility when the patient presents with the signs of pleural effusion due to the compression effect on the lung parenchyma. Okay, it is our responsibility to identify the cause of the pleural effusion, treat the condition so as to avoid morbidity and the mortality. Well, let us go about some of clinical manifestations of the patient with pleural effusion. Well, this is the X-ray chest of the patient with pleural effusion, which shows opacity in the right base. There is obliteration of the costophrenic angle. That is called the meniscal sign. In the PA view of the chest, when the meniscal sign is positive, that is, when the costophrenic angle is obliterated, it denotes there is an accumulation of fluid more than 200 ml. Okay, this we are going to talk in the diagnostic evaluation of the patient with pleural effusion. Then, how does the patient present with the clinically? When there is minimal fluid in the pleural space, the patient is usually asymptomatic. In the beginning of the pleural effusion, there is a stage of dry pleurisy or pleuritis. This is called the pleurisy, which manifests as severe pain, which could be over the shoulder or across the chest wall or over the abdomen, or it may be at the back of the shoulder radiating down the limb, depending upon the dermatome that is involved. The patient complains of severe cutting pain, crescendo and decrescendo due to inflammation of the pleural membrane. When the fluid gets accumulated, the pain gradually disappears, giving a false impression of improvement, which is not true. Then patient gradually develops shortness of breath because of the impaired ventilation secondary to the compressional effect of the fluid getting accumulated on the lung parenchyma. And the patient may present with the symptoms of underlying disease, which could be pneumonia or systemic inflammatory conditions. The pneumonia may present with presence of fever, cough, and expectoration, and systemic disorders may present with the presence of organomegaly, besides signs of pleural effusion. Well, when you examine the patient with pleural effusion, there will be diminished movements of the chest on the side of the effusion, impaired percussion note, diminished VF and FVR, and diminished breath sounds. Well, there is bronchial breathing above the border of the pleural effusion with eugophony. With these clinical signs and symptomatology, you may easily make a provisional diagnosis of pleural effusion. When there is a large effusion, there could be signs of mediastinal shift with the tracheal shift and the apical impulse shifted to the contralateral side. Well, there could be a widening of the intercostal spaces in large pleural effusion. Well, these are the clinical presentation which will help you to make the provisional diagnosis of pleural effusion. Then go about to confirm the diagnosis with the laboratory evaluation before you treat the patient actively. Go for the X-ray chest. X-ray chest will identify the presence of opacity, obliterating the costophrenic angles. If you take the PA view, look at the meniscal sign that is obliteration of the costophrenic angle. When the meniscal sign is positive, it denotes there is a presence of more than 200 ml of fluid in the pleural cavity, in the PA view. But in the lateral view, 50 ml of fluid is sufficient to produce meniscal sign. Well, when there is a fluid in the pleural cavity, by identification of the X-ray chest, do the thoracentesis to collect the pleural fluid to send it for the laboratory evaluation. Rapidly check the pH, check the protein content and the cellularity, that is a differential diagnosis, and differential count and the total count. When there is reduced pH, that is less than 7.2, and there is elevated protein and low sugar content in the fluid with the elevated neutrophil count, well, you have to rapidly go to the chest tube drainage, which will help the patient to clinically improve with the insertion of the chest tube. And then go for the other biochemical tests like LDH and do the cytology to eliminate malignancy. Check the gram staining and send it for culture and sensitivity to use the appropriate antibiotic. Chest ultrasound is more sensitive to diagnosis as well as a guide to the thoracentesis. Chest CT is more remarkable for the diagnosis of pleural effusion. Well, these are the various steps of evaluation before you proceed with the treatment. This is the slide showing the ultrasound of the chest with patient in pleural effusion. This is the normal side. This is the sign of this is the side which is showing pleural effusion. This is the sign of pleural effusion. This is spine. This is the liver. Yeah. Ultrasound is more sensitive than the X-ray chest. This is the CT scan of the malignant pleural effusion. This is the massive pleural effusion that is evident in the CT chest. Then we'll touch briefly on the treatment guidelines. Rapidly proceed with the chest tube drainage when you identify the pleural fluid having low pH, high protein content, and low sugar content, and evidence of neutrophilia. Chest tube drainage, you need not put large bore tube. Tube of 10G or 12G is sufficient to drain the fluid adequately. Put the appropriate antibiotic for the rapid recovery of the patient. But if the patient is not improving with chest tube drainage and antibiotic coverage, go with thoracoscopic decortication. And if there is recurrence of the pleural effusion, you are dealing with a patient with malignant effusion or with benign pleural effusion of lupus, rheumatoid arthritis, or uremic pleural effusions. In these conditions, though they are benign effusions, recurrence is very common. Well, in patients who are resistant to the above lines of treatment, you can go with the fibrinolytics. That is intrapleural instillation of the fibrinolytic agents, which will improve the drainage and facilitate the early recovery of the patient from pleural effusion. Well, when you are dealing with the patient with pleural effusion with chest tube drainage, do not remove the fluid more than 1500 ml, which is going to complicate re-expansion pulmonary edema. Instead of getting the patient improved from the clinical symptoms, he is going to worsen his symptomatology with regard to shortness of breath. Well, do not forget to take the check X-ray chest following chest tube drainage. Why do you take the check X-ray chest? This is to know the presence of residual fluid and also to know the presence of pneumothorax, which is iatrogenic and traumatic pneumothorax. So do not induce trauma to produce traumatic pneumothorax. Okay? This is the care you have got to take while dealing with the patient with pleural effusion. Coming to a note on prognosis. Well, prognosis depends upon the cause of pleural effusion. So the benign pleural effusions, mostly the transitive pleural effusions, once you treat the cause, the patient is going to improve dramatically. So you need not treat the pleural effusion actively, but if you treat the underlying cause in transitive pleural effusions, patient is going to improve. Say, for example, you attend to the treatment of congestive heart failure in a patient with cardiac pleural effusion. The same way, treat the nephrotic syndrome in renal pleural effusion. Correct the hypoalbuminemia in nutritional disorders. So patient is going to improve without any recurrence. So the prognosis is relatively good in transitive pleural effusions when compared to exudative pleural effusions. Well, malignant effusions have poor prognosis because of the condition underlying the malignant pleural effusion is malignancy, which is relatively resistant to treat. So the recurrent episodes of malignant pleural effusion, they have the poor prognosis. Well, if you encounter a patient with benign pleural effusion, if you cannot treat it properly, that may end up in empyema. So do not take the benign pleural effusion simply, but handle them carefully in order to make this patient improve without consequences of empyema. Well, this is all about the pleural effusion, a brief talk on this. Thank you very much for patient listening. Hope you enjoyed my talk. And my dear students, please remember the important points related to the pathophysiology of the pleural effusion and the importance of identifying the patient with pleural effusion and evaluate appropriately and give the treatment effectively in order to avoid morbidity and mortality in the patients with pleural effusion. Thank you once again for patient listening. We'll meet you again in the next class. Until that time, bye-bye.